Hello everyone and welcome back to the MedMax channel. Before we dive in, a quick reminder. If this lesson gets 10 likes, I will upload a complete PDF cheat sheet on all heart blocks and conduction disorders. It will have all the criteria, diagrams and ECG examples. It is perfect for a quick review. And at the end, we will break down a tricky NCLEX-style questions, which we discussed in previous video. And today it is all about blocks. Alright, let's discuss conduction disorders, which is AV blocks and bundle branch blocks. It is critically important topic. If dysrhythmias are problems with source of impulse, the blocks are problems with its conduction. The road is there, but it is clogged or completely blocked. And the number one rule you must take from this lesson is this. The danger of a block depends on how low it goes. The lower it is, the more dangerous. Let's break it down step by step. Alright, let's start from AV blocks, which means the delay at the AV junction. The impulse starts in the sinus node but can't travel properly through the AV node or his Purkinje system to the ventricles. There are 4 degrees, but remember them as 3 groups by the danger level. First degree AV block, which is a slow POC. This is just a delay. Every impulses eventually get through, but it is slow. On the ECG, you see early P wave followed by a QRS, but the PRI is consistently long, more than 0.2 seconds. You can imagine it as a slow elderly security guard checking every pass. Causes is often just aging, medications like beta blockers or digoxin or increased vagal tone. Practically, it is not a danger, it is stable and benign. Management tools just monitor, no emergency treatment needed. Alright, next is second degree AV block, type 1 or Wenckebach. Think of it as a thyroid runner. This is where it gets interesting. The conduction gets progressively slower until one impulse doesn't make it all. The classic ECG pattern, longer, 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 drop. You see the PRI getting longer with each beat, then a P wave without a QRS, and the cycle repeat. So, why it happens? Fatigue in the AV node itself. It is usually due to medications. Inferior myocardial infarction, which affects the AV node's blood supply, or high vagal tone. Danger still relatively low. It rarely progressive to complete block. Management usually just observation and remove the cause, like medication. For symptomatic bradycardia, you can use atropine. Now pay close attention. Here's where the danger level jumps. Second degree AV block, type 2 or Mobitz II. The intermittent saboteur. This is not in the AV node. The block is below it, in the more fragile his Purkinje system. The ECG pattern is completely different. The PRI is constant and normal, but suddenly, out of nowhere, a P wave is not followed by a QRS. It just drops. And why it is so dangerous? Because of conduction system below the AV node is unstable. This can suddenly and without warning turn into third degree block. The ventricular rate can plummet. The key NCLEX fact: atropine often doesn't work here because the problem is below the node. The heart escape rhythm is too slow and unreliable. About management. This is a red flag. It often requires temporary pacing and preparation for permanent pacemaker. And now the most dangerous, third degree AV block, complete heart block, which is a complete divorce. This is it, the most dangerous one. There is no conduction between the atria and ventricles. They beat completely independently. On ECG, you see regular P waves marching along at their own rate, for example 80 beats per minute. And you see slow white QRS complexes, which is an escape rhythm, at their own, much slower rate, like 40 beats per minute. And of course, there is no relationship between them. You can see symptoms like severe bradycardia, hypotension, syncope, or Stock-Adams attack, confusion, risk of cardiac arrest. This is a true emergency. Management is immediate transcutaneous pacing. Permanent pacemaker is almost always needed. Medications like atropine or epinephrine are only temporary bridges. For mastering it, you need to burn this into your memory. Which blocks are usually benign? First degree and type 1. Which blocks require immediate pacing? Type 2 and third degree. Now let's go even lower. What if the impulse gets through the AV node but then gets stuck inside the ventricles? There is a bundle branch block. Main idea: a bundle branch block is a delay in the right or left bundle branch. The ventricles can't depolarize quickly via the normal highways, which is a Purkinje fibers. So the electricity spreads slowly from cell to cell. This makes the QRS complexes wide, more than 0.12 seconds. Crucially, bundle branch block is not a rhythm problem. It is a conduction problem. The rhythm can be perfectly normal sinus rhythm, just with wide QRS. Here we have some options, which is a right bundle branch block, ECG signature. Look at lead V1. You will see a classic rabbit ears or RSR pattern, like the letter M. The QRS is wide, which means the right ventricle activates late. The left ventricles go first, then the impulse spread to the right. Causes can be a normal variant, also seen in pulmonary issues like a pulmonary embolism, hypertension, or sometimes ischemia. Key point: often benign. It usually doesn't hide sign of heart attack on ECG, and it's less concerning. Next is a left bundle branch block. ECG signature totally different. In V1 you see a deep, wide S wave look like a big valley. In V6 you see a broad, notched air wave like the letter M, turned sideways. It means left ventricle activates late. The right ventricles goes first. Causes is almost always pathological. Think long-standing hypertension, cardiomyopathy, coronary artery disease, aortic stenosis. The NCLEX golden rule: new left bundle branch block plus chest pain. Suspect acute heart attack until proven otherwise. And left bundle branch block completely masks the ST segments, making ECG diagnosis of ischemia impossible. For management, you need to treat the underlying heart disease. It is a major red flag for structural problems. Now let's discuss the fascinating and dangerous combinations: bifascicular and trifascicular blocks. This is advanced, but you must know it. Bifascicular block. Any two of these three pathways are blocked. Right bundle branch, left anterior fascicle, and left posterior fascicle. The most common is right bundle branch block plus left anterior fascicular block. Why it matters? Because this conduction system is now on its last leg. The risk of progression to a complete third-degree heart block is high. Trifascicular block. This is when there is evidence that all three fascicles are diseased. On ECG, this can look like a bifascicular block plus a prolonged PRI, which is a first-degree AV block. Now NCLEX action. A patient with bifascicular or trifascicular block who is faint needs a pacemaker. This is a clear indication. Alright, how about discuss a strategy? Let's tie it all together with our universal frameworks from previous lessons. To analyze any cardiac problem, ask 3 questions. First, where is the problem origin? Sinus node, atria, AV junction, or ventricles. For blocks, it is at AV node higher, which means safer, or below, which means lower or dangerous. Second question, where is the problem? Rate and rhythm. Too fast, too slow, chaotic, or early beats. For blocks, the atrial rate is often fine, but the ventricle rate is slow or dropping. And the third question, how does it conduct the wiring? Narrow QRS, supraventricular, versus wide QRS, ventricular or bundle branch block. For blocks, Mobitz II and Third-degree often have wide QRS escape rhythm, telling you the block is low. Let's do it as short as possible. The hierarchy of conduction danger, from least to most dangerous. Level 1, just watch. First-degree AV block, Wenckebach, isolated right bundle branch block. Level 2, concern. Mobitz II need pacing evaluation. And level 3, urgent. Third-degree block need pacing now. New left bundle branch block with symptoms. And level 4, critical combo. Bifascicular or trifascicular block with syncope. Alright, now it's time to discuss challenging questions from previous video. A 6-year-old patient with a history of ischemic cardiomyopathy and prior myocardial infarction is admitted to the emergency department for dizziness and palpitations. ECG shows a wide complexes tachycardia at 180 beats per minute. The rhythm is regular, QRS complexes are uniform in shape, a P-wave are not associated with QRS complexes. And question is, which of the following is the most appropriate immediate intervention? And correct answer is B. Perform synchronized cardioversion, and that's why. First of all, we need to identify the rhythm. It's wide complexes tachycardia, regular rhythm, uniform QRS morphology, IV dissociation, P-wave not associated with QRS, history of ischemic cardiomyopathy, plus prior myocardial infarction. This is look like monomorphic ventricular tachycardia until proven otherwise. At second, assess patient stability. The patient is hemodynamically unstable, hypotension 82/50, alterated mental status, which means confused, diaphoresis, symptoms of poor perfusion. This look like unstable ventricular tachycardia with a pulse. All this information lead me to the step 3. Apply the advanced cardiac life support algorithm. Unstable tachycardia with pulse, immediate synchronized cardioversion. This is a core ACLS rule. And finally, if this video was helpful, please give it a like, it is really support the channel. And remember, 10 likes unlocks the detailed PDF summary for you. If you are new here, subscribe and hit the bell so you don't miss the next part, which is a connection causes with violation, all about the heart problems and the rhythm changes. You can leave your questions or topic you find confusing in the comments below. And once again, this is a MedMax channel, medicine made simple.